Good evening, everyone, and welcome. We are so glad to have you here. This is a topic that comes up in numerous of our groups, and we're so glad that we can talk about it more. We just want to let you know that obviously none of this can be taken as medical advice, and anything that you learn tonight always run through by your doctor. We especially want to give a humongous thank you to Janssen, Johnson & Johnson, Pfizer Oncology, Bayer, Advanced Accelerator Applications, Foundation Medicine, the Promise Prostate Cancer Trial, and BHL Alliance. Now, the person who is coming up right next is beloved to ANCAN, one of our advisory board members, and has actually participated in some of our groups to further education. So Pamela, thank you so much, and off you go.
Alexa, always good to be here, and thanks for having me. Dear audience, it's wonderful to be here. You will see we have two amazing speakers who I will introduce in just a second. But most importantly, I would like to share a little bit why I'm passionate about germline testing. And one is that, like, I've been a medical oncologist for many, many years. When I was diagnosed with breast cancer at the age of 48 and with not a clear family history and certainly not any definition of risk for a germline mutation. And I was realizing that not only did I have a BRCA mutation, but my grandmother's breast cancer at 65 and what she ultimately died of was also probably pancreatic cancer. Was really instrumental knowing that I had a BRCA mutation, and then realizing then when my father at the age of 78 had heartburn, and rather than just giving him an NSAID, we worked him up with an MRI and detected his pancreatic cancer, and without much symptoms, his BRCA2 related pancreatic cancer was already 9 centimeters in size. Because he carried the BRCA mutation, we switched his therapy around a little bit, and within 8 weeks, he had a pretty amazing response going to surgery. And then he lived with his pancreatic cancer that ultimately came back for almost 6 years. So I think clearly, not only is important that, you know, to have a BRCA mutation for prevention and early interventions, but as you hear from our speakers, having a hereditary mutation can really change the way we approach patients with several cancer, prostate cancer being one of them, but also breast cancer and pancreatic cancer as well as ovarian cancer. But most of all, as a breast cancer oncologist, I don't want to see any more large tumors in my clinic that could have been prevented had we known that such an individual had a BRCA mutation. So needless to say, I'm very biased, but I feel very, very strongly of broad population testing for germline mutation who's at risk. And so I'm hoping that you find tonight's presentation really helpful for not yourself, but maybe for talking to with family members, talking to friends. And with this, I think back to Alexa, or do you want me to introduce the first speaker?
No, Pamela, you'll just introduce both of them.
Okay, so we have two speakers today. We have Marnie Brisson-Tierno. She is a nurse, but has a PhD in pharmacology. She is the director for medical liaison at Foundation. She's passionate about genomic testing, like testing for targets in the tumors that we can address with specific medication. That includes, of course, BRCA mutation. And as you will see when she presents, she's a very passionate, driven young woman. She's also very much a dog lover. If you see the backgrounds in her room, these are a lot of dogs she's been rescuing and taking care of. So very much looking forward to her presentation. This is followed by Dr. Channing Paller. She's a medical oncologist at Sibley, Johns Hopkins. She'll talk about the Promise trials and how to use genetic mutations for specific targets and specific oncologic management. Her personal passions is really a range in how we personalize medicine for individuals, including PARP inhibitors, including other maybe more natural medication. And I think it's really important that we really get across taking care of patient is a very comprehensive approach. We want to take in consideration their personal needs, their personal genomics, their needs and wishes. And I think Dr. Paller is also a mother of young children, so having her plates full, and as you can see, both of these women will be very, very excited about presenting some of the data to you. And again, as Alexa said, we don't provide direct medical advice for individuals. Please do check with your daughter, whether with your doctor, whether any of the advice you hear would be applicable to you. With this, back to Alexa, and let's get started with the presentations.
Okay, good evening. Can everyone hear me?
Yes.
Yes, we can.
Excellent. Well, good evening, everyone. I am Marnie Brisson-Tierno. As Dr. Munster already introduced me, it is an absolute pleasure to be here this evening. And I really thank everyone, the patients, family members, healthcare providers, and any caregivers that have joined us this evening. And I'm excited to talk to you about advances in biomarker testing for patients with metastatic cancer. So if you give me 1 minute, I will, there we go. These are my disclosures. And so this is the agenda that we're going to be talking about this evening. The first part of the discussion will be the rise of biomarker-driven treatments for cancer patients, where I'll discuss the differences between genomic and genetic testing. This will be followed by recent advances in biomarkers to guide personalized treatment choices for patients with metastatic cancer. In this section, I will describe the various targetable gene alterations and corresponding targeted therapies using lung and prostate cancer as examples, and then focus on complex biomarkers known as microsatellite instability and tumor mutational burden. And these can identify patients that may respond to immunotherapies. And then finally, I'll conclude with advances in detection methods to identify these actionable biomarkers by discussing the differences between liquid biopsies and tissue biopsies. So let's start with the rise of biomarker-driven treatments for cancer patients. So when it comes to cancer treatment options, here we are taking a look at where we started compared to where we are today. So in 1920 through 1940, we were limited to two main treatment options, which were radiotherapy and chemotherapy. So this is a one-drug-fits-all approach because these treatments are not specific to a patient's individual tumor biology. Now, in 1998, the first targeted therapy was approved, and this was Herceptin for patients with breast cancer. And then in 2010, we had our first immunotherapy approved. Now, in the present day, we have multiple targeted agents that are available, even combinations of these therapies that are personalized for cancer patients based on comprehensive knowledge of gene alterations and biomarkers that are driving the growth of the patient's tumors. Comprehensive genomic profiling of a patient's tumor can assist in finding the right treatment strategy for each patient. With genomic profiling, we're analyzing hundreds of genes within a patient's tumor to identify all potential genomic alterations or immunotherapy biomarkers that are driving that patient's tumor. We can also identify alterations that may be causing resistance to a particular therapy. The results may then provide the option for targeted therapies that are specific to those genomic alterations or biomarkers that will allow for immunotherapy. We can also look into clinical trials if there are no FDA-approved targeted agents available for the specific tumor alterations or biomarkers that have been identified. Even if we do not find anything actionable in a patient's tumor with genomic profiling, this still provides important information because then providers may have to resort to chemotherapy as the best option for the patient. Now, I just described genomic testing to identify gene mutations, but these mutations can also be detected through genetic testing. There are two types of gene mutations that we may find in tumors. A somatic alteration occurs when DNA is exposed to cancer-causing agents, such as the ones you see on the right-hand side. Exposure to these various risk factors, such as smoking, will cause DNA damage and gene mutations. These somatic mutations occur spontaneously during a patient's life and can be detected with genomic tumor testing. With germline mutations, these are specifically inherited from your parents and can increase the risk of having cancer for you or your family members. Because these gene mutations are inherited, they will be present in every cell in your body. So as Dr. Munster already mentioned, genes such as BRCA1 and BRCA2 normally protect people from developing certain cancers by repairing DNA damage. But when you inherit a mutation in a gene such as BRCA1 or 2, DNA cannot be effectively repaired, and this puts you at a higher risk of developing cancer. Germline mutations can be detected through tumor testing, but in order to truly determine if it's an inherited germline mutation, genetic testing must be done to confirm. When it comes to genomic testing, this is performed using tumor tissue or circulating tumor DNA in a blood sample. And we'll talk more about these detection methods later. Genomic testing identifies gene mutations from a patient's tumor and can detect both somatic mutations that are not inherited and germline mutations that are inherited. Because remember, germline mutations are found in all cells, including the tumor cells. However, genomic testing cannot definitively tell us if a detected gene alteration is somatic or germline. Therefore, if a particular gene mutation is found with genomic testing and is suspected to be germline, follow-up genetic testing should be performed for confirmation. Since inherited gene mutations can be found in every cell, they can be detected with genetic testing using saliva or blood. Gene mutations that are found by both of these testing methods can influence treatment decisions. So that means whether or not the mutation in BRCA1 is germline or somatic, it could be targetable by specific targeted agents. So now let's discuss these different types of gene alterations and advancements that have been made in lung and prostate cancer. So shown here are the different types of gene alterations that can be present in cancer genes. The purple and white stripes represent a non-mutated or normal gene. Next to that, you see an example of a copy number alteration. So that's where we detect an abnormal number of copies of a gene, often referred to as amplification. A substitution is a mutation that exchanges one base pair that makes up that DNA sequence of the gene for another. Insertion mutations are where extra base pairs are inserted into a new place in the DNA gene sequence. For deletion mutations, a section of the DNA gene sequence is lost or deleted. And finally, rearrangements are where segments of the DNA sequence within a chromosome break and then rearranges to areas of the chromosome that can align with another gene and then form a fusion. This image represents how gene mutations or alterations can lead to uncontrolled cell growth and tumor formation. Mutations in cancer that are in cancer-related genes can lead to altered proteins being formed in the cells. So these proteins are part of cell signaling pathways that control cell functions, such as signals to start and stop cell growth. If these proteins are altered, this can lead to uncontrolled growth and ultimately tumor formation. Therapies are designed to target these altered proteins that are formed by the mutations in their genes. So let's look now at examples of gene alterations and corresponding targeted therapies that are available in different tumor types. So shown here are the multiple gene alterations that have been discovered in patients with metastatic non-small cell lung cancer. This is a really busy slide, and that's actually a good thing because it's showing how far we have come in discovering the multiple drivers of metastatic non-small cell lung cancer and the therapies that have been developed to target those drivers. So the first targeted therapies for lung cancer were focused on the EGFR protein receptor. Several types of mutations within this protein, such as substitutions, insertions, and deletions, have been discovered, which have led to multiple targeted therapies being developed. However, there are many types of alterations in different genes that can be targeted in lung cancer, such as fusions in the ALK, ROS1, and RET genes. We're now seeing a major shift in increased survival and improvements in quality of life for patients with metastatic non-small cell lung cancer because of all of these therapy options. There have also been recent discoveries of new targeted therapies to specifically treat patients with metastatic castration-resistant prostate cancer. There are several options now for these patients for therapies that target androgen receptor function to regulate how testosterone drives cell growth. And those are shown at the top where you see abiraterone, enzalutamide, apalutamide, or darolutamide. In 2017, an immunotherapy called pembrolizumab was approved for any patient with a tumor that was considered to be microsatellite instability high or mismatch repair deficient. Now, we'll talk about this complex biomarker in a minute, but I wanted to mention that this was the first, what they call a pan-tumor approval for a targeted therapy, meaning it doesn't matter what type of cancer you have, as long as it is MSI high, then you can receive pembrolizumab. So this is a therapy option for prostate cancer patients. Another pan-tumor approval for pembrolizumab came in 2020, where patients with any type of cancer where the tumor mutational burden was found to be high can receive this immunotherapy as well. A groundbreaking discovery also came in 2020, where PARP inhibitors such as olaparib and rucaparib were approved for metastatic castration-resistant prostate cancer patients whose tumors were being driven by mutations in genes called homologous recombination repair genes. These genes are responsible for repairing DNA mutations in cells. Though we do not see as many gene mutations and targeted therapies on this slide as you saw for the lung cancer group, I want to assure everyone that research continues so that we can make more advances in discovering more drivers and more targeted therapies for prostate cancer patients. So now let's discuss these complex biomarkers in more detail, specifically microsatellite instability and tumor mutational burden. So the buildup of mutations in a tumor cell that comes from microsatellite instability and a high tumor mutational burden will allow for a better response to immunotherapies, or they're otherwise known as immune checkpoint inhibitors. So a patient's immune system will target a tumor cell to destroy it because T cells will recognize multiple mutations in a tumor cell as being foreign. So mutations are represented here in orange. However, a braking mechanism is in place, and that's shown in purple, where PD-1 and PD-L1 interact and prevent the T cell from destroying the tumor cell. If a patient receives an immunotherapy, like what's shown in green, this therapy releases the braking mechanism and then allows the T cell in your immune system to attack and destroy the tumor cell. So why is high microsatellite instability a biomarker of response to immunotherapy? We first need to understand how a tumor cell ends up as MSI high. So we have several pathways in our cells that are responsible for repairing DNA damage that occurs every day in our cells. One of these pathways is known as mismatch repair. When the proteins that are responsible for mismatch repair are intact, DNA is successfully repaired. However, if there are gene mutations that cause defects in these proteins, we end up with mismatch repair deficiency, and DNA is not repaired. This leads to a buildup of mutations and changes in regions of our DNA called microsatellites, leading to a microsatellite instability high status. It's also important to note that mutations in the genes responsible for mismatch repair can be somatic, but they can also be germline alterations. Germline mutations in these specific genes are associated with the hereditary condition known as Lynch syndrome. This describes how multiple mutations in a microsatellite instability high tumor allows for a tumor cell to respond to immunotherapy. So let's start with microsatellite stable tumors on the left, which have very few mutations because the mismatch DNA repair pathway is intact. Mutations will be presented by a tumor, which is shown in the orange circle, to help an immune cell interact with a tumor cell. There's also an interaction between tumor and the immune cell by the proteins PD-1 and PD-L1 that act as that braking mechanism that I already mentioned. When these proteins interact, they prevent our immune cells from attacking the tumor. However, if we interrupt that interaction with an immunotherapy that's shown here as an anti-PD-1 antibody, this allows the immune cell to attack. The problem is if we have only one mutation to allow the immune cell to interact with the tumor cell, which is seen in microsatellite stable tumors, we will see poor responses to immunotherapy. In a microsatellite instability high tumor that has deficient DNA mismatch repair, multiple mutations are available for the tumor to strongly interact with immune cells. This allows for a good response to immunotherapy. Therefore, the more mutations that are present in a tumor cell, the higher likelihood of response to an immunotherapy. The frequency of MSI high tumors is varied across different tumor types. You'll notice that endometrial cancers, gastrointestinal cancers, and specifically colorectal cancers have the highest frequency of tumors that are detected as MSI high. There's a lower frequency for prostate cancer. However, it can be up to 5% of prostate cancer patients that can have MSI high tumors where they could then receive immunotherapy. A tumor that is noted to be tumor mutational burden high also has a buildup of DNA mutations that can allow for a better response to immunotherapies. There are several factors that can lead to high TMB, and this includes defective DNA repair pathways, smoking, and exposure to UV light. Again, the percentage of tumors that are TMB high is varied based on tumor type. You'll notice that the highest percentage of patients with TMB high tumors are those with lung cancer or melanoma. And this is to be expected since our lungs and our skin are exposed the most to environmental factors that can increase the number of gene mutations. There's a lower percentage of TMB high tumors in breast, colorectal, and prostate cancers. So now we can move on to our final topic, discussing advances in detection methods focused on tissue and liquid biopsies. There are technical differences on how DNA is extracted from a tissue biopsy specimen compared to DNA we can obtain from blood. A tissue specimen that was obtained from a previous biopsy or surgery is stored in pathology labs as a tissue block, where there will be a concentrated amount of DNA available. This specimen is sent to a lab where pathologists will determine if there's enough tumor tissue to extract the amount of DNA that's needed for analysis. We can also extract tumor DNA for analysis from a blood draw, and this is known as circulating tumor DNA. I'm often asked why we do not just do liquid biopsies on everyone, since drawing blood is easier and it's a lot less invasive. So the reason for that is there's many factors that can affect the amount of circulating tumor DNA that we can obtain through liquid biopsies. Tumor cells and tumor DNA can be shed directly from tumors into the bloodstream. We can detect circulating tumor DNA in approximately 75% of cancer cases, but that also means that approximately 25% of tumors do not shed adequate amounts of DNA into the blood. Now, healthy tissues can also shed DNA into the bloodstream, and the total amount of cell-free DNA in the blood is made up of circulating tumor DNA and DNA from healthy tissues. The issue is that the fraction of circulating tumor DNA may be less than 1% of the total amount of cell-free DNA that we extract from the blood for analysis. In comparison, we can expect to see 20 to 40% tumor DNA from a tissue biopsy specimen. The reason I brought this up is that trying to find the circulating tumor DNA amongst all other DNA in a patient's blood sample is similar to finding a needle in the haystack, compared to the more concentrated DNA that could be extracted from a tissue biopsy. There are also several factors to consider that can affect the amount of circulating tumor DNA in your bloodstream. So the tumor type, the timing of the blood draw, and the type of therapy can also affect circulating tumor DNA levels. Tumor tissue specimens are therefore still considered the gold standard for genomic testing, as you have access to larger amounts of DNA, and it's also the most sensitive method for detecting all types of gene alterations. But then who are the patients then who could benefit the most from liquid biopsy? And so the first is patients in whom a traditional biopsy is inaccessible or impractical, such as tumors that are difficult to access. Patients in whom a traditional tumor biopsy has insufficient amounts of tumor DNA would also be a good example. This can happen when tumor tissue has already been used up by other testing procedures, or if the biopsy tissue obtained is too small and doesn't have enough DNA. And finally, patients who have disease progression or relapse on current therapies are the best candidates for a liquid biopsy. When a patient has detected disease progression, tumors are actively shedding larger amounts of DNA into the blood. It's also beneficial to look at circulating tumor DNA at the time of relapse on therapy because new gene alterations can be discovered at that time that may assist with selecting the next treatment. So we're going to conclude with a specific patient example. And so this is a patient who was 68 years old with advanced prostate cancer that came to the oncology clinic after being treated for 2 years with abiraterone treatment. So remember, abiraterone is one of the therapies that reduces testosterone levels that would drive prostate cancer. Now, the problem is that this patient's prostate-specific antigen levels are rising. So that's an indication that the patient is no longer responding to that abiraterone treatment. So this particular patient wanted to avoid chemotherapy and was interested if there were any oral options available. Now, this patient also had a bone biopsy that had been taken 2 years ago. What I didn't mention yet is that it's often difficult to obtain the DNA from a bone biopsy specimen. So therefore, what can you do in order to perform genomic testing for this patient? So the provider decided to use liquid biopsy and sent that for genomic testing, and what was found was a BRCA2 mutation. Now, the report also indicated that it was highly possible this could also be a germline mutation. So this patient was started on the PARP inhibitor olaparib and then was referred to genetic counseling because they also may need to have genetic testing. And so that concludes my portion of the webinar. And I wanted to thank everyone for attending today to learn more about this important topic. And I hope that I've empowered you to ask for biomarker testing because it can provide all potential therapy options that may be available to you. And I also wanted to ensure everyone that clinical trials continue to find new targeted therapy options for all cancer patients. So thank you very much. Did we want to take questions, Alexa?
No, we're going to take questions at the end so we can ask both of you.
Okay. Then I will pass it to Dr. Pollard.
Terrific. That was an incredible presentation, a hard act to follow. Thank you all for the opportunity to come here and present on the PROMISE study, which it was a nice sort of intro to end with a prostate cancer patient as a place to start. So I want to say thank you to the families, to the caregivers, to any providers on this call. I want to thank the organizers. And so let's get started and talk a little bit about the PROMISE study. So you now are all experts on DNA after that beautiful talk. Let me see if I can get my slides to go forward. Here we go. And we're going to talk about genes and cancer risk and why your genes matter. So this will be a little test if you were paying attention to the first presentation. And then we're going to look at a couple case studies and how genetic testing can lead to targeted therapies, talk a little bit about that. And then what is PROMISE and why it might be right for you. And we'll end with questions and discussions. So let's start with genes and cancer risk and why your genes matter. So as we all know, our body is made up of cells, and in the cells there's a chromosome, and in the chromosome there's DNA, and in the DNA there are genes, and every gene has a job. I'm smiling because last week my 5-year-old started camp, and he came home and said, "Have you heard about the sonic hedgehog gene?" And I was like, "What?" They teach 5-year-olds in camp about sonic hedgehog genes. And they said, yeah. He said, yes, snakes used to have hind legs, and their sonic hedgehog gene has been silenced, and sometimes they can have mutations, and sometimes they can stop working. But anyway, snakes don't have legs anymore, and that's how they lost their legs. That's a little bit of evolution mixed in with genetics, but I thought that was great that they're even teaching 5-year-olds in camp about genes. So today we're going to talk about cancer protecting genes, and that examples such as BRCA1 and 2 are genes that help protect our body from developing cancer. So genes can have mistakes. We learned they're called mutations, and they can be acquired randomly over time, and they can be acquired with chemical or radiation exposure. For example, it's summertime, we go out, enjoy time by the pool or playing outside, and you get a sunburn. And most of us can, put lotion on and heal ourselves, but sometimes patients, cells don't slough off and don't repair themselves, and they develop into cancer, such as melanoma. And so it's really important that we monitor for these. And they can also just happen as mistakes as cells divide over time. And then some mutations are inherited, or they're passed on from parents. So as we said, there's sort of 3 main ways cancer can happen. And 10% of cancer is hereditary, so it's inherited from your parents. So you can see on the right, the father, the male, has a colored in mutation. The red color is supposed to represent the mutation in the right chromosome, and he passes it to one of his 2 offspring, and that's an example of an inherited mutation. So there's a couple ways that we can get the data. So one, on the left, you see an example of germline testing. We'll talk in a minute about different ways here. I have an example of a saliva sample. And so we know with germline testing, the gene is present. So if it's present, it's hereditary cancer, and this may help determine treatment options. It also may help determine your risk for you and your family members for developing other cancers. And then if the gene mutation is absent, then, it could be by chance. So on the opposite side, on the right, if you're doing somatic testing or cancer tissue testing, the gene mutation is always present there, and it also may help determine treatment options, as we just nicely saw. All right, so let's talk for a minute about cancer patients' medical journey. This slide is overwhelming because it is overwhelming. It is good that there are so many people to help a cancer patient, but it's also overwhelming to navigate, and that's why we often have nurse navigators to help patients through this process. So if we start here in a patient's journey, usually patients present with symptoms, or sometimes no symptoms, but usually they present with weight loss or pain or some sort of symptoms, and then a diagnosis is sought with different testing, a CT scan, MRI, a biopsy to determine the diagnosis. And once all the testing is done, they meet with the team, and they come up with treatment choices. And the therapy cycle begins, and hopefully they go into survivorship. And unfortunately, sometimes they go into disease progression. So you can see down below the healthcare professionals along the patient journey, nurses, general practitioners, oncologists, pathologists, radiologists, surgical oncologists, surgical nurse, radiation oncologist. So there's a variety of people that help along the way. And we're going to talk about some others or at least one other that's not listed here. So when do we do genetic testing? Well, once we figure out the diagnosis, we really want to do genetic testing because it could affect treatment decisions. And so it is essential to do that as part of testing. Sometimes patients don't have a good tissue to biopsy that's accessible or safe to safe or enough for them to send for testing. Sometimes even it's not circulating in the blood, so you can't send it to Foundation. And so we like to do germline testing as well as somatic testing oftentimes. And in that genetic testing, they get a lot of results, and it's overwhelming. And so a genetic counselor is also brought in oftentimes at this point to review those genetic results, review the implications for the patient for their own risk of developing secondary cancers or developing cancers and their own risk of passing it on to their offspring, and also talking about who should be tested in their family. And so this is sort of the key point where genetic counselors can add to this patient's journey. All right, so let's talk a little bit about some case studies about how genetic testing can lead to targeted therapies. I don't know if any of you saw this in the news back in 2019. Beyonce's dad, Matthew Knowles, had breast cancer, which is rare but still happens for men, and he was found to have a mutation that actually is found to be quite common in African Americans, and we should be testing for it more. And so he is at risk for other cancers, prostate cancer. So it's really important that we get genetic testing and know which cancers to screen for. Similarly, Angelina Jolie shared her journey of having a BRCA mutation and deciding to get a bilateral prophylactic mastectomy to prevent her from developing breast cancer as prophylaxis. And that was very personal, and it was amazing that she was able to share that with the world to help people understand the importance of inheriting a mutation and knowing your germline genetics. All right, so currently, I would say this is evolving, as we could see from that beautiful slide for lung cancer treatment options, but much of medicine is still sort of old school, which is you have a heterogeneous population, people, colors of the rainbow, and they have a diagnosis, and you give them the therapy for that diagnosis. And a third of the time it has a great effect, a third of the time it stabilizes the disease, but nothing impressive, and a third of the time it causes adverse effects and the disease progresses. And you're like, what was that for? And it's really disappointing. And so finding targets and biomarkers that help us predict when patients will respond to therapy is really the way of the future. So as we know more genetic information, we'll be able to know more precision and personalization. So without naming all of the markers, if you're not familiar with MSI and tumor mutation and BRCA, it's as simple as if you have green genetics and we know a green pill works for you, that's great. And when the yellow people are matched to the yellow pill and the blue people are matched to the blue pill, and then everybody has a beautiful effect. And it goes from a 33% response rate to 90% response rate, and we can really be excited. I mean, it's sort of fun to go to clinic when I'm treating targeted patients because I know they're going to respond well, and it's really a positive experience. All right, so let's talk for a minute about what is PROMISE. So this is a new research opportunity to bring precision medicine to the fight against prostate cancer. So a few years ago, we started getting these biomarker specific trials, and we were having a hard time filling them because Foundation Medicine wasn't screening everybody, or they were, but the clinicians weren't. People weren't getting germline testing, and insurance wasn't paying for it. And if we couldn't even find the patients with rare mutations, how did we test if our drugs worked against them? So we could find the blue people and the green people and the yellow people. And so this is a really exciting, unique collaboration among patients, physicians, and researchers that can help improve and save the lives of prostate cancer patients now and in the long run. It is a national registry, and we are working on moving it internationally. So it stands for Prostate Cancer Registry of Outcomes and Germline Mutations for Improved Survival and Treatment Effectiveness. And I would say that if you look up in the top corner, Washington State, my co-PI, Heather Chang, and myself, in Baltimore and DC, Channing Paller, we worked together, and it was just a wonderful collaboration with the Prostate Cancer Clinical Trial Consortium, who has worked with the top 10 cancer centers in the country to help bring multiple new drugs to prostate cancer and get FDA approval over the last 10 years. And so by working together with our sponsors, Advancing Cancer Treatment, it's given us a wonderful opportunity to provide free genetic testing and counseling for prostate cancer patients, 5,000 of them throughout the country. So how does it work? I think that everybody should practice going to prostatecancerpromise.org, and people can look at the videos. There's a video from one of my patients. There's a video from one of Dr. Chang's patients. There's a video from some of our colleagues, and you can see sort of the how-to of it, their experiences of it. There's one patient that shares his inherited gene and the impact it's had on his daughters. And I've watched the video no less than 10 times, and I cry every time. There's 2 minutes in the middle. We can share that snippet in the chat. It's really powerful to see the impact that this bit of knowledge had on his life in terms of helping him have a better prognosis and have targeted therapy that he could tolerate better, and also how he could look out for his daughters. And so I highly suggest you watch some of those. But anyway, how do we do it? If you have prostate cancer, any stage, we welcome everybody. Or even if you know you have a mutation, we want you to, even if you got tested a different way, get registered. Learn if Promise is right for you. We're going to ask you information about every 6 months, and we'll get that from your physician and ask about your experience as well. And in return, we're going to give you a lot of free information about current prostate cancer guidelines, about new research, about anything genomics related. So initially, we're screening 5,000 people from around the US, and then we're going to follow 500 with mutations so we can better understand information about these rare mutations and treatments that work and don't work. So then what do? So you get the DNA test kit at home after you fill out, hey, I have prostate cancer, Gleason 4+3, and this is the doctor I want the report sent to, and we'll ship you the kit, and then 6 weeks later or less, you get your results and you review it with a genetic counselor. And if you do have a gene mutation, we suggest your family get tested. You have that discussion with the genetic counselor, and Color will do it for a reduced price at $50 per family member, unless they can get it for free with their normal doctor in clinic. All right, so why might Promise be right for you? Well, more than 4 million American men are fighting prostate cancer, and the instructions and are written in their genes, and so is the risk. And so if we can figure out that you're at risk and that you have a target that we can target with medicine, I think that is something that every man with prostate cancer should know. I actually think every human should know. I think you should know it like your blood pressure, but that's my personal bias. All right, so in the fight against prostate cancer, we want you to take these simple steps. Register online. Provide a saliva sample for germline testing. Do it from home. Keep your existing doctor and do it all for free. It's free, it's easy, it's pandemic friendly, it's economic friendly. I see no reason not to do it. And in return, you get your free genetic profile information, you get free genetic counseling, someone to help you talk to your family if you want to, but you don't have to. And information that can impact available treatment options, ongoing updates on prostate cancer, and different research. And you also get the opportunity to be a hero and help improve future treatments for other prostate cancer patients like you with germline mutations. So here's the website, prostatecancerpromise.org. I hope that you take a peek and look at some of the videos and see what you think. And I'd love to take any questions. All right, let me stop sharing.
Alexa, do you want me to read the questions and move the questions on?
Yes, I sent them to you in the chat. Thanks so much.
I see that. For Dr. Cherno, can you explain in understandable terms the significance of microsatellite instability and whether the high or low status can change? As the prostate cancer may have recurrence many years after initial biopsy, should genomic testing be repeated on future biopsy specimens?
Yes. Okay. So this is a great question because there's a lot of research going on about that right now. From what the initial research is showing is that mutations can increase over time, especially with the various treatments that a patient can receive. So if you can imagine, when you're starting off and receiving the first treatment versus down the line, if you've received several treatments, you're gaining mutations along the way. So a patient could start out not being TMB high, but then after several therapies could end up being TMB high later on down the road. And right now, the immunotherapies are not typically given for prostate cancer patients until they have already received all of the standard of care therapies up until that point. So that is really the point at which immunotherapies would be available anyway. So it can change over time.
Okay, a study done by Dr. Kishan found that there is the genomic signature that can predict how a patient will react to radiation therapy. Is this available yet?
There is one company, I believe, that has a predictive algorithm based on gene expression, but that is specifically in early stage, if I remember correctly. And I will tell you that there is a lot of research and work that has been done to try to find a sufficient profile that can really predict who would benefit from radiation therapy or not. I can tell you from a lot of the radiation oncologists that I've spoken to, they're not convinced yet that that particular signature is truly predictive of whether or not a patient will respond. But it'll be solely based on the opinion of the radiation oncologist that you would see.
In the world of prostate cancer, the Decipher test helps predict the benefit of who's more likely to benefit from adjuvant radiation or radiation after surgery. And so in my world, that's the context that my radiation oncology colleagues use it in.
Okay, Dr. Paller, a question for you. Is there a cost to participating in Promise?
It's free and it's easy. The only cost is you have to put saliva in a little tube, and the minute it takes you to sign up and the minute it takes you to put it in the mail. It comes prepaid. It is completely free. Zero.
It's if you can elaborate a little bit, this is pretty much the same test that for all other tests in that color has, not just the standard color test. If anyone's seen it, it's the same test, right? It comes nicely in a box in your mail. You do the swab and you send it back. Is that the same way?
That's right. That's exactly. So if you have ever seen a color test, it is exactly the same. It is their standard color kit that tests for 30 genes for a variety of different cancers, not just prostate cancer, breast cancer, but their whole entire 30 gene panel. And it's so you can look at which genes it tests for on their website, but it does all 30. And you provide the sample, you send it back, and in a pre-packaged packaged container, And then you get an email and a phone call about 6 weeks later from a genetic counselor to review your results.
I can tell you my 18-year-old son who wanted to get tested did this, and he ordered this all himself, and he found it quite manageable. I think the one thing that was really hard for him, not to eat anything for 30 minutes being a teenager.
Yes, that is true. That is true.
Okay, for both of you, for tissue-based somatic testing, how does RNA sequencing fit into this?
So RNA is typically used, it can be used in a couple different ways. So RNA is typically used to really confirm a fusion. So sometimes I mentioned that is one type of genomic alteration, is a fusion. And there are some times where when you do a DNA analysis that it's not 100% clear that a fusion has actually been formed. You can use RNA to confirm that that fusion is part of the patient's tumor. But another way RNA is used is for expression profiles. So a lot of the early stage testing for prostate cancer uses RNA expression to look at the expression of a subset of genes that can give an indication of how aggressive that tumor may be, if there is a higher risk for relapse down the road. So that's another way that RNA can typically be used. Dr. Poller, I don't know if you want to add to that.
I think that's a good summary for this level. I think there's a lot of research looking at it as another potential biomarker to help us figure out what the prognosis and the predictive value of treatments.
So Dr. Poller, a question on why is genetic and genomic testing not done for every patient? Why is it not done routinely?
You know, that's a great question. I
wondered that myself, and I agree with you. So.
I had this argument actually with someone from the UK who was very resistant to urologist, and he said, "Why would I do it? It doesn't affect whether or not I perform surgery. They're not going to pay for it, so I just have an angry patient, and it doesn't affect my management." And I want that answer to change in the next year or 2 years because of informational webinars like this and other ways. Right now, insurance pays for them sometimes depending on what the NCCN guidelines say, right? If the patient's metastatic. I often argue that I have a clinical trial early stage for them, and so they should pay for it if they haven't already. But most of the reasons is that they're not on the NCCN guidelines is making an impact on treatment decisions at that point, and thus insurance doesn't pay. Is my understanding. So you tell me.
I want to speak a little bit about the breast practice because unlike you folks, I see a little bit more breast cancer patients and in the BRCA clinic for particularly. So when the adjuvant, so when someone has breast cancer and they have a tumor that gets removed and they have high risk tumor and they have a BRCA mutation in the germline, they now get a PARP inhibitor in the adjuvant setting after chemotherapy for a year. And this has shown actually an amazing amount of benefit. So anyone with a BRCA mutation, BRCA1 or BRCA2 in the germline will benefit from the PARP inhibitor, olaparib, and more to be tested. Now, it is really important to know that there's a benefit, but I think it's really also important to understand that when we test a patient, we then immediately learn about the family risk. And I think what Dr. Poller also says is like, it's not just important to know what the risk is of the patient in front of you, but as a physician, we essentially care of the entire family and caregivers. So knowing that someone has a germline mutation that they could have passed on to their children or that their parents carry. Often we see young women come in with they find they have a BRCA mutation, then we learn that their mother also carries a BRCA mutation. and she then gets appropriately screened. And I think more often than not, it's like a lot of women who are older are now faced with this, like they never really were aware of their risk for a genetic mutation because they haven't been tested, because historically we only tested young women with breast cancer and family history of breast cancer. And I think the benefits of the PARP inhibitors are changing this. And I think it's important to know that the patient with the BRCA-related prostate cancer gets tested, but it's really important that his daughter or his sister also gets tested. And I think that's why I think it's so important to have these genomic tests and know how affordable they are. Do you want to speak
and
a
then
little
do
bit
the
about
follow-on testing, right, with the genetic counselor, right? Because the current doctor is not going to treat the whole family personally necessarily, but they do need to meet with someone who will.
The Immudex test is supposed to predict how bad checkpoint inhibitor therapy side effects might be. How accurate or reliable is this test?
So I do not want to speak to that only because I don't know enough about the data. So I really would not want to speak to something that I'm not very familiar with. But that is definitely something to talk to the physician about, because they are definitely going to have an opinion as to whether or not that is an effective signature to give them the indication of that or not. I will say that there is a lot of research going on right now to be able to verify who may have more side effects than others from immunotherapies, for sure.
Okay. Can the genetic genomic promise testing result in impact on insurance eligibility?
Yes, I hope so. I hope not only will it get someone who has a BRCA2 mutation's whole family paid for free genetic testing, but I hope that it will also have an impact of matching a BRCA2 patient with the appropriate therapies, or an MSI patient with pembrolizumab or other immunotherapy. I hope that over the next 20 years that we follow patients, we'll learn more about rare mutations, not just BRCA1, 2, but 5% here, 2% here, that all add up, and we can really make a difference so that the prostate cancer slide can look a little bit more like the lung cancer slide. I don't treat lung cancer, but I keep one lung cancer patient who I found in 2009. He crawled into my office and said, I'd rather be dead than have another cycle of chemotherapy. I sequenced her. It wasn't Germline, it was Somatic, but she had an EGFR mutation, and she has been on erlotinib and thinks I'm her lucky charm. And so she just tells me about her fun trips, and I've watched her grow old with me from 60 to 74, and she's sort of my inspiration. And I think I luckily have got to experience that with prostate cancer patients, right? I have a 60-year-old who said, I don't want to tell my job. I don't want to tell anybody. I can't believe my cancer is back. The surgeon and radiation oncologist promised me they cured me. And now, I have to tell my kids I have a BRCA2, and I luckily had a PARP inhibitor trial for him. And so he's been on a lap rib for 3 years, and he thinks I'm the greatest thing since sliced bread, right? So yes, I hope that we have lots of these stories, not just, I even have one 92-year-old who said, send me to hospice. I said, let me check one thing. He had a BRCA2, so he's been on a lap rib for a year. And then I had another one who was 94, who again, luckily, they checked him in Florida, and he was MSI high. So I have him on pembro alone, because they tried to give him docetaxel, and the side effects were terrible. You shouldn't be getting chemo to a 94-year-old. Right, so yes, I hope there'll be thousands of these stories as a result of Promise, and just new convention that because we're talking about it, that you all go tell your doctors and everybody gets tested. And Dr. Munster's patients with breast cancer, I mean, everybody should get tested.
And you brought up too the clinical trial aspect, and it's so important because even if there isn't a targeted therapy that's available, there could be mutations found in the tumor with testing that could make you eligible for a clinical trial. And then therefore there's more options available, which is so important. So it's, I really, really believe in testing, and that's why I'm here tonight, because education is everything. And like I said, I hope that it empowers people to ask about testing if it's not brought up to them by their physicians.
Okay, turning this a little bit around, is like, do patients have to worry if they do germline testing that they get barred from getting insurance or penalized? It's like a lot of patients earlier on were worried that they would then be labeled as having a pre-existing condition. Can you guys speak a little bit more to that? This is mainly my question.
So there is a law that protects patients from certain things, specifically long-term sort of disability, employment, but there are rare cases where it's not protected, and so you should always talk to your physician about your situation. I don't know, Dr. Tierno, if you have anything to add to that, or Dr. Munster.
I would say
the GINA law should protect you from having concerns. Of course, no one knows for sure, but so far I have to say I've been running the hereditary cancer clinic and I've not seen a single patient having had insurance problems. I think me personally, I feel like the risk of not having appropriate therapies and having a cancer that could be treated with a targeted therapy, or having a family member who could gone undergoing screening and then not have a cancer detected at late stage, outweighs any risk of this. And
yeah, I agree. I have not heard of a patient yet that was denied insurance from results of testing. Actually, the opposite, that in order to, as you said, to get the targeted therapy that could fight against what you have found with testing, you have to have that testing in order to get insurance approval for that drug. So the doctor has to be able to say, this patient has a detected whatever gene mutation, so I need you to approve this therapy for the patient. And I will also say too that for testing in general being paid for, Medicare pays for all genomic testing basically in the appropriate setting. So right now it's metastatic patients, advanced cancers, in order to find targets. And then private insurance, it's becoming better and better every day in terms of coverage. So it's becoming more and more available to everyone. And my hope is that it's available to everyone, no matter what your insurance may be. And there's also financial assistance programs as well at many of these testing companies, so that if a patient is not insured, or there's a question about whether or not they're going to have coverage for testing, then financial assistance can go into play so that the patient can get that testing.
So one of the tricks I use with my patients who don't have insurance or can't pay is that oftentimes the newer genetic companies, as they're getting started to establish themselves, if the patients can't pay the $5,000 or it's their second tumor, they only get one $5,000 cost. We go to a new one that completely forgives the cost if they can't pay, because they usually have great funding when they're just starting out from VC firms. So I would say shop around and plan ahead.
yeah, and I think there's a lot of clinical trials and options available. It's like I think usually make it work for patients. Switching topics a little bit, and one of the questions actually for our introducer stuff, and that's like, is there an ideal diet? Is there ideal nutrition? Is there ideal nutrition for certain mutations? Like, Dr. Pallett, you want to take this first?
Sure. I encourage patients to sort of eat a heart healthy Mediterranean diet. I would say there's different literature. We know, too much selenium is bad, right? We know too much vitamin E is bad. We've done some of those trials. We know that meat too often is associated with an increased risk of colon cancer. We know that burned protein is a carcinogen that basically is like your prostate smoking a cigarette. Don't do that. So burned meat is a carcinogen that is bad for you. So I never let my father eat burnt meat on the grill. He never liked that, but I don't recommend it. We know, so we encourage fish, healthy omega-3s. We encourage a plant-based diet with a lot of green veggies, legumes, high in fiber, all the healthy fats. And so I think there's, I have a bunch of research going on based on the Physicians' Health Study showing that people with a certain genotype have a benefit from more antioxidants. If their antioxidants are low, they have a higher risk of aggressive prostate cancer, and if their antioxidants are high, they're protected, a tenfold difference. This is work out of Physicians' Health Study, and so some of my antioxidant work in the biochemical space is sort of based around, screening 500 people to get, 80 with certain mutations and seeing if antioxidants help them. And so I think it's always better to eat your food than swallow pills. And get exercise. So I know we're supposed to separate it, but I think meditation, I think exercise, and I think diet are really important. So I always encourage my patients to stay away from anything white except for cauliflower and white asparagus, and really eat lots of green and a whole array of colors. So that means no potato, no white potatoes, yes, sweet potatoes, no white rice, no white bread, no white pasta. All right, I'm interested in what you guys say.
So thank you for bringing this up. So I want to, even though I'm the host, I want to weigh in a little bit because I was born in Switzerland, and we hear a lot about the Mediterranean diet, which is our southern neighbors, despite the fact that the Swiss lived the longest. Or now I think we're overtaken by the Japanese. But for the longest time, and it's been quite a difference for me to have lived in the United States for the last 30 years. And having so much focus on diet, and I would say, and I think this is probably with heresy, eating less food and eating food that tastes good and is not processed is probably a good start, because I think obesity is a real thing in the United States and probably in the rest of the world. And while breast cancer is not clearly an obesity-related cancer, we know that if you have breast cancer and you eat a balanced diet, you do better. I think there's many cancers that are associated with obesity, such as endometrial cancer, probably prostate cancer. So I think having a balanced diet and really having a normal weight is important, and exercise. I think the exercise is becoming more and more stronger as an evidence and as an anti-cancer modality. And I think the important part is for a cancer survivor. So we make a lot of effort keep patients alive longer with cancer and longer. So what we know is like obesity and excessive food is associated with more cardiac risk factors. So it's kind of like not quite fair to expect us to keep patients alive and then the patient doesn't want to do their contribution and eating healthy and exercising and being as fit as possible. Marnie, you're smiling.
I was the only thing that I was going to add, you already did, was that, I mean, and I kind of try to live this philosophy as much as I can, but fresh food is the way to go. Processed food is really what, can cause a lot of these issues that we've been talking about. And, there's unfortunately been a rise in colon cancer cases in young people in this country specifically. And it's thought that, you know, diet could be a big factor in that. So, you know, it's eating fresh foods that are not processed and, you know, is really the best way to go. And completely agree with you on the exercise factor, because the stronger you are, you know, the better it's going to be to fight off any cancer that, you know, is around. It's being stronger is always going to make you a better fighter.
Dr. Paller, you want to weigh in a bit more on the diet? I think this is an exercise, particularly as it pertains to prostate cancer, because I think it's an important topic.
Sure. I completely agree with you that eat foods that taste good and eat less of it. One of my leukemia colleagues used to remind me we've cured mice of cancer hundreds of times by starving them. And so it's one of the ways to make sure we don't develop disease. I had an excellent nutritionist work with me for 10 years, and she recently retired, but she also was sort of very clear that prostate cancer patients and the data for them, they should not be having a lot of milk. They could have a little cheese, but she really wanted them to get their calcium from leafy greens. And so her diet for my patients, was a bowl of fresh fruits with some protein and healthy fat, whether that be eggs or oatmeal with something, and nuts or flaxseed. And then she, for lunch, have some, either a big salad with some salmon or chicken on it, and then for dinner, similarly, or even you can have some legumes, and then for dinner, your carbohydrate would be either squash or sweet potato, right, or whole wheat. And then, but really, I'm saying, just like everybody else here, drop the processed food, right? Make your carb veggies, not bread, right? I really, I know maybe that's heresy too, but I eat gluten-free, partly because I don't even want any of, but not to go eat my own rice pasta, right? I'm eating, my carbohydrates are raspberries and watermelon and chocolate on occasion, right? And God forbid. So I think it's really important to continue to eat healthy. I have a lot of studies that in Hopkins is sort of known for them. We've had Chinese grass seed oil, pomegranate, muscadine, grape skin. The main components are resveratrol, ellagic acid, and they seem to have some activity. Curcumin, there was a study of green tea, curcumin, and so it's still unclear if it's just slowing down the rise in PSA, because we don't have survival studies. We just sort of have PSA progression and metastatic progression-free survival data. But it is interesting that some people really slow their PSA doubling time, how fast their PSA doubles when they go on sort of these high dose antioxidant diets. And so actually right now, one of the compounds that seemed to show a significant slowing in a phase 2 trial, I had a phase 3 trial of this placebo controlled. So we're going to find out for sure, does that genotype, do 25% of people really benefit from antioxidants or not? And if not, then we'll go back to saying, eat a healthy, well-balanced diet, because it's better to eat your fruit than pop pills with antioxidants in it. And so we'll continue to explore that data, but it's still better to eat a whole food plant-based diet.
And then the last the question is more like a comment. ACS has a fund to pay for testing. Before we wrap up, I want to get both of you an opportunity to have some parting words, and I know you both feel very strongly about testing. Any recommendations, anything you want the listeners to take away from this evening that you want to stress? Maybe Marnie, you could start.
Sure. I would say, I spent time talking about the differences between genomic testing and genetic testing. One thing that I want to be clear is, because I completely agree with everyone that has spoken tonight, that genetic testing is so extremely important. and we need to know what is going on in the family history. It's vitally important. And so I want to make sure that it's clear that genomic testing to find alterations in a tumor is not a substitute for genetic testing. So I mentioned that you can find potential germline mutations with tumor testing, but to be absolutely sure if it is a germline mutation, you have to get that follow-up genetic testing to be absolutely sure. So I just want to make sure that everyone understands that it's not one or the other, that both types of mutations can be used to make treatment decisions, but they are very different testing modalities for different reasons. It's finding mutations in a tumor versus finding an inherited gene mutation that has to do with your family members.
Dr. Pallett?
Sure. I think I want to put plug in for Promise and really say it's free, it's easy. Please get genetic tested if you haven't already, and if you have a known mutation, we would love to have you in our cohort. Whether we become part of a patient education group or you're private and want no one to know anything and you're just willing to give us, share your information privately with us and get free information about potential clinical trials for your mutation around the country that you would be eligible for, or your family, or anything else, we would love to have you. So please check out prostatecancerpromise.org.
And I can only echo this because, when someone has a hereditary mutation, and so far, if anyone had in the breast clinic, if someone has a young mother with breast cancer, and then for the daughter, then the question always been like, what's the risk for me? And if the mother has an identified mutation and the daughter does not have this mutation, we call this a true negative, then that daughter actually does not have to worry about breast cancer. Whereas on the other hand, it's like if you have a mother with a BRCA mutation, we start screening at 25. And that's very different than what you would do with the general population in the US, right? So having a mutation that you know about makes a big difference for the life of a woman. And at the same time, from when with prostate cancer, we start PSA testing probably just after 40, and we wouldn't do this otherwise, and we do a much more rigorous test. So it really has, testing a patient has such implication for the rest of the family, I think, which is a really important part to get across. And I think what Marnie says is true, like we need to test the tumor sometimes to target our therapy, but then we also need to do germline testing to really care for the rest of the family. Rick and Alexa.
I'm here. Hello. Just a couple of little things. I was monitoring the chat, Dr. Palla, and a couple of people have had some issues in signing up for Promise. Somebody asked, how do you sign? I think that's you just type your name in digitally. Is that right?
That's right. You just type your name in digitally. If you have any problems, we have Natalie, our nurse navigator or patient navigator, should be able to get help on the website. But if there should be a help email to send questions to. If it's a small group, they can send it to you and send it to me, and I'll get it answered. But yeah, so digitally, you just type your name. Easy. What's next? What are my other questions?
I wanted to give a plug to a really amazing webinar we did with Dr. Pamela last year. We did more than one because Pamela hosted for us. But Pamela was part of an incredible webinar. We have done a series called The Talk, where we have somebody with a condition talking to somebody else in their family who may or may not have the same condition. And we did one on inherited mutations. And in that, we had, I think, 3 or 4 different pairs. And one of the pairs was Pamela and her son, Max. And they had a conversation about what happens if you have an inherited mutation in your family. And it was really, really moving. And we've put the link in the chat window for everybody, so you can go listen to that. And we had another pair. The dad has actually been listening in because I saw a question from him, who had passed on a BRCA mutation to his daughter. And they talked to each other about what the implication of that is. And we had a fabulous host, a genomic counselor, Lindsay Byrne, who works at the James at the Ohio State Cancer Center. We have for a long time been really, really sensitive to the issues around germline inherited mutations. And I have to give a shout out right now to a board member, an advisory board member who was really dear to us, Professor Bill Burhans, who was a yeast geneticist researcher at Rosalind Park, and who passed on BRCA mutations to his daughters. We lost Bill to prostate cancer about 2-3 years ago, but I think it was working with Bill closely and Bill being a part of our support group that really made us so aware of the importance of germline testing and the huge burden that really is often inherited by the other family members, and they don't know how to respond to it. And I don't know, Pamela, before we close out, would you like to say anything else about that? I mean, you live with this, you live with it. I think only one of your 3 kids has tested so far, right?
2.
2 have tested.
And 2 are positive, so. And you know, my oldest son wanted to be tested when he was 18. We tried to talk him out of it, but he said, I just assume I'm positive, so I'd rather know. And when he was positive, the first thing he said, like, hopefully this means that my sister is going to be negative, since I know statistics don't work out like this, but you know, that was his point. But I think, you know, it's very clear, like when you carry a mutation, you worry about your risk for cancer, and that worry is always there. And the guilt of having this passed on is always there. But now that I have 2 generations, my father was positive, and my son is positive, my brother is positive, so I don't hold this against my father. You know, it's like so, and that's what my son said to me, like, we didn't hold it against your father, why would you think we hold it against you? But you know, as a mutation carrier, you do worry. And like Rick, it is really interesting, like particularly in this very, very strongly politically charged environment of the recent Supreme Court decision, you know, what to do with pre-implantation diagnostics, and just to hear how our younger generation feels about that, you know, like pre-implantation selection. So I have to say, like, this has been the mutation has been an incredibly enriching discussion with my kids, because they feel very strongly, you know, about what to do and with the mutation, when you should get tested. And it's interesting to learn from the young. I was lucky. I learned when I was 48. I didn't have to worry all my life about living with a mutation. The young people are different, and it's really interesting. And I really like for you to have more of the younger voices on your panels, Rick and Alexa.
Well, hopefully we'd like to work with the BRCA Center. As you know, we've been trying to set up a virtual support group for kids with inherited mutations for a long time, and We've gone to Force, we've asked them, but if there's a way that we can do it, we think they need as much support as the person who's actually carrying the mutation. You know, not just the ones like Max who know, but the ones whose parents have a mutation and they don't know. They need a tremendous amount of support too. So we're going to keep talking to you about that. I want to thank, this has been a wonderful panel. This has been a fantastic panel. I personally have a debt of gratitude to Foundation Medicine for all the support that they've given me and ANCAN in getting us started and off the ground. And I always love working with Foundation Medicine. I am very, very happy to do this first presentation with the Promise team. We know Dr. Cheng, but we didn't know Dr. Palla until today. So now maybe we'll get you back in and we'll have you talking specifically to a prostate cancer audience. And I urge all of you to sign up for that Promise trial if you haven't done so. And we love Dr. Pamela. That's why she's on our advisory board. That's why we keep asking her back. That's why she's got so many ANCAN t-shirts and sweatshirts. We have to keep asking her back so we can get the whole family dressed in ANCAN t-shirts and sweatshirts. And I also don't want to forget a shout out to our own ANCAN team that produced this webinar, to Alexa, who is always fantastic and who did this today with 101 degree fever. God bless her. And to our backup, Joe Gallo. For those of you who don't know, if you don't, we host about 25 meetings a month for all kinds of different conditions, from prostate cancer to multiple sclerosis and quite a few things in between, and some mental health programming. Everything we do is free, and so check us out on our website, ancan.org. And thank you everybody for what is a great webinar today, and it will be posted. It is recorded, it will be posted, and you'll be able to listen to it again. So thank you very much, and good night.